getting it, and I wanted to know more and more about it. And they all, the ones that had gone through successful treatment, kept telling me about the Seattle program. And I didn't know at that time that Dr. Sylvester was a key person up there. And that Seattle program led the way for programs around the country. Certainly here in Sarasota, we're fortunate to have him. He is with 21st Century Oncology. His office is out at Lakewood Ranch area. I'm sure he would be a great resource for anybody, even if you just do a consult to find out what the parameters of prostate cancer and its repercussions are. That was one of the most, the greatest learning experiences I ever had was when I went to sit down with him. A couple of people had recommended him, and I thought, you know, I'm a little nervous about going to sit down. Sat down with him, we must have spent an hour, and he described every incident of what could happen to you in certain circumstances. And I still got the package that's that thick from his office that day. Tremendously informative. And I use it, I sent it to my brother the other day, who just as recently been diagnosed. And so I encourage you to listen to what he has to say. He certainly knows a lot about this subject matter. Dr. John Sylvester. And thank you for coming.
Thank you very much. So, yeah, I was in Seattle for 23 years, and then moved down here in 2010. Our program there, 3 of us have set it all up. 2 guys are older than me, they retired, but a lot of young guys don't want to work, so it's time to leave the rain and come someplace sunny. So, folks out here I trained invited me to come down and do this, a few other places. This looked like the best location. I'm glad I came here. One of the first things I saw when I got to the beach was this little baby turtle going out. I thought that was kind of cool. Anyway, what we're going to talk about is treatment of recurrent disease. But at the end, if you have other questions, we can certainly go over that. And I think number one, as far as recurrent disease, is you want to avoid recurrences. So that means picking the treatment that has the best success rate, up front for most people. And then we'll also talk about how you manage recurrence after radical prostatectomy, after external beam radiation, after brachytherapy, and after cryo, but mainly after surgery or IMRT. That's where we see most of the patients. So, to prevent recurrence, number one, you want to catch the cancer in an earlier stage, right? So, and then you want to treat again with a treatment that has low side effects. We'll go over a little bit about this right now, and that has to do with PSA screening. For a while there, around 2012, task force came out recommending don't do PSA screening. It does more harm than good, but it was based on a study that was very flawed. And they finally backtracked, and now PSA screening is recommended again. But we had a period there for several years where guys weren't getting PSA screened, and we saw high risk of metastatic disease start going way up again because of that. But basically, the death rate from prostate cancer was going up and up and up and up. Up here, prostate cancer, that's lung, but prostate cancer was going up and up and up. And then PSA screening came in right about here, and it takes a couple years to catch up with all those people. And then you see the death rate goes down 45% in the United States with PSA screening. So PSA screening is critically important. So digital rectal exam and PSA screening. You've got to do the digital too, because some of the bad cancers don't always make a lot of PSA. Now what we found in surgical studies is that the risk of having disease in the lymph nodes was quite a bit higher in 1987, right? PSA screening first started, but once it had taken off for a while, the risk of lymph node invasion was very small. So, and catching the cancer with very early stage disease was much more common. So, catch it earlier, better cure rates. In our own data in Seattle, we saw that the first patients that were treated with radioactive seed treatment, brachytherapy, with ultrasound guidance in the country were done by us in Seattle, 86 and 87. And this is intermediate risk disease, kind of your average prostate cancer, Gleason score 7, and or PSA between 10 and 20. And this is the first year we're doing it, so we had to teach ourselves, so the quality of the implants weren't that great, okay? And this is right about the same time frame, just a couple years later after we've been doing seeds for a couple years, and now we're doing a good job, and see the cure rate's much better if you do a good job versus not such a good job, all right? But look what happens with PSA screening. after PSA screening takes effect, you catch the cancer earlier. Because back here with intermediate risk disease, guys had like all their needles positive. They had high volume intermediate risk disease. But with screening, you get low volume disease, so like 1 or 2 needles out of 12 positive instead of like 10 out of 12 positive. So the screening improved the cure rate dramatically because the treatment didn't change that much between this time frame. So with radiation, there's two, we'll talk about surgery a little bit later, but with radiation, there's 2 ways of doing radiation. One is with external beam radiation, the other is with brachytherapy, which is radioactive seeds for the most part. The beam therapy gives a small dose every day, Monday through Friday, 5 days a week. Cancer cells are not good at repairing radiation damage. Normal cells are good at repairing radiation damage because we live on a radioactive planet, and if our bodies didn't repair radiation damage, we wouldn't be alive. If you go to the beach for 12 hours, what happens? You get a bad sunburn, right? Go for 5 minutes a day, nothing at all. So that's why radiation is a small dose every day, Monday through Friday, 5 days a week. Usually for 8 or 9 weeks, although some programs are starting to look at maybe trying to shrink it down a little bit. Seeds are put in the prostate once. Takes 20 minutes to do it, outpatient, under anesthesia, and they lose their radiation at a small dose per day. But since they're treating from the inside of the prostate rather than through the outside, you get a much higher dose. So you get like 2 to 3 times higher dose of radiation with the seeds than you would do with the beam. And all the studies show the higher the dose you give, the better the cure rate. So with beam therapy, there's a lot of things that are done, but nowadays the radiation can avoid the rectum nicely. We have a balloon in the rectum, which pushes the prostate against the bone and holds it still. There's some studies I did in Seattle, equipment that was available there, show that if this is the prostate and this is the beam, while the guys are laying on the table for 5 minutes getting treated, we had a machine that could track the prostate position 20 times a second. We saw that every single patient that was treated, its prostate moved out of the beam while the beam is on. So the only way to keep that prostate in the beam is with the balloon in the rectum. So we've got all the 21 C sites from Venice to Bradenton trained on how to do this, but they're the only sites on the west coast of Florida that do this. Miami does it, MD Anderson does it, they do it in Jacksonville, but unfortunately a lot of centers are a little squeamish about putting a little balloon in the rectum. It's really easy to do, but it helps make sure that when the beam is on, it's treating what you want to treat, not treating the rectum. And that was this Calypso device that showed that the prostate moved. And if you had the balloon in, it didn't move very much, but without the balloon, it moved a lot. The seeds, you're asleep in the OR, we put the probe in the rectum and place needles through the probe into the prostate through the skin, and the skin is clean, so the risk of infection is like virtually 0. And we drop the seeds off. See, there's 2 needles here, there's the guy's seeds. 2 needles, seeds. 4 needles, seeds. Top to bottom, 20 minutes, outpatient, and then they're back home that day. Most advanced way of doing seeds are stranded together in a strand. That way they stay put. Patients don't pee them out. They don't go to the lung. They stay where they're supposed to be. If you use loose seeds, they might go. They go to the lung, they go out the bladder, and you don't get a good quality implant that way. Other ways of doing treatment is freezing the prostate with cryotherapy. That was real popular about 15, 20 years ago. External beam radiation, which we talked about already. Another way to do external beam is called proton beam therapy. You go on the internet, you see a lot of stuff written by Proton. If you look closely, it usually says AD. That means it's an ad. You gotta watch out for ads. Cure rate is not better, and the published complication rates are not lower than protons. Matter of fact, some of the data shows worse. And the newest type of proton, which is the standing proton beam, at the national meeting I was just at a few months ago, showed it had worse side effects than the older proton. So they thought that, hey, the newer protons could be better. Actually, it was worse. Worse. So newer is not always better. Surgery can be open or robotic. Almost everybody does robotic. They're equally good, but the robotic, you're out of the hospital quicker, a little less bleeding. So virtually everybody does robotic surgery now. But the cure rate's not any better than the open technique, and the risk of reconnaissance and impotency isn't any better. But you're out of the hospital quicker, so might as well do it. So, when we look at outcomes, we break it down not by stage for prostate cancer, we go by risk categories. Low risk, intermediate, and high risk. So, and we're gonna in a couple of years, this is gonna be changed. This is gonna be very low risk, low, good intermediate, bad intermediate, high risk, and very high risk. We're gonna split these up. But basically, most patients have intermediate risk disease, Gleason score equals 7, or the PSA between 10 and 20. Starting to see a lot of guys with more high risk disease lately. Seen a lot of Gleason 9 cancers, and those are pretty aggressive. Memorial Sloan Kettering, on their website, they have a nomogram. That's incorrect. We published papers on it. The surgery part might be correct, but the radiation part is incorrect. It's almost 25 years out of date. All right, so you can't trust it. Matter of fact, they say on the nomogram the success rate should be 87%. We published that as 99%. They were looking at the patients that Dr. Glasser Grimm and I treated in 1988 and compared to guys who had surgery in 2003. And people changed how they Gleason scored around 1995, so you can't do that comparison. So here are the outcomes of the different treatments. So when you look at relapse-free survival, the chance of cancer goes away and doesn't come back. Now, when you look at outcomes, it can be confusing. Because you might hear someone say, well, the success rate with treatment X is 99%. You got a 99% chance you're not going to die of prostate cancer if you get this certain treatment. Well, that could be true if you got no treatment at all. Because even if you don't get treated and the cancer spreads to your bones, you can get hormone therapy and still live 5 years. So that doesn't tell you how effective the treatment is. The way you tell how effective the treatment is you get that treatment and the cancer doesn't regrow anywhere in the body, back in the prostate, in the bones, or anywhere. Not only are you alive, you're alive with no recurrence of disease. That's critically important to know the difference. And these are the top centers in the world for prostate cancer outcomes by low risk, intermediate risk, and a high risk. So let's just focus on intermediate risk, okay? So what you see is most of these studies have 5 years of follow-up. It means they follow the patients for 5 years and publish their results. Memorial Sloan Kettering, with radiation beam for 5 weeks followed by Cs, 89% of their patients have no recurrence. Cleveland Clinic, 89% no recurrence. Seattle, the patients we treated, 92% with 9 years of follow-up. Temporary Cs called HDR, 87% success rate. A temporary C treatment, some people call it high dose. It's not high dose, it's high dose rate. The radiation goes quicker. The dose is actually lower. The first patient treated in the country was done by my partner Tim Bate in Seattle in '89, and we just made up the protocol, treated guys for 10 years, and we found the cure rate wasn't quite as good as seeds, so we stopped doing the HDR. Some people still do HDR. That's probably better than regular external beam radiation. The dose is lower than seeds. Surgery, the top center in Europe, Hamburg, Germany. You have a 66% success rate, taking the prostate out. Mayo Clinic, 65% success rate. Johns Hopkins, 76%, and Cleveland Clinic, 79%. So why is surgery lower than this? Anybody have any ideas? If you take that prostate out, how can the recurrence rate be worse with surgery? They didn't get it all. There's microscopic disease outside the prostate. With intermediate risk disease, you've got a 20 to 40% chance it's outside your prostate in the fatty tissue microscopically. You can't see that on an MRI scan. The surgeon cannot see that in surgery. So they can take out the prostate, they're not getting the cancer. So that's why it recurs. But what about beam without the seeds? Full course radiation beam, 78% relapse-free survival. That's also with 6 months of hormone therapy. Now, the advantage of the beam over the seeds is that you get less temporary urinary side effects. So if you got a guy who's got kind of a big prostate and bad urinary side effects, he may not be a good candidate for seeds. So he'll want to do beam, knowing that there's a higher chance of recurrence, but it's not a whole lot different than surgery. So as a new experimental protocol, and some of you guys got a handout on that, and we can get more for you if you need, it's called Prostatat. And the initial study done at Baylor, which uses a virus, I inject a adenovirus into the prostate. That inserts a gene into the cancer cells. Then you take pills that attack the cancer cells that have that gene, and the pills kill the cancer cells. At the same time, you give regular radiation. And they had a 95% success rate. with being, and these pills didn't really have any side effects, okay? So you had the advantage of cure rates equal to seeds, but not the side effects, the temporary urinary side effects. So that's pretty cool stuff. The problem is there's only 21 patients in this study. So it's not proven. So we're doing a randomized trial, 2-to-1 randomization, so 2/3 of the guys get the real gene, 1/3 don't. So for the guys that aren't candidates for seeds, it's great to get on this trial because you got a 2/3 chance you can have a better success rate, which gives you an ultimate success rate around 90%, which is pretty darn close to seeds. Proton, 69% success rate. HIFU, 63%. This is from the top center in Europe. The most modern patients treated with whole gland HIFU. So this is the best of the best again. And a big review, British Journal of Urology, the top centers doing cryotherapy, 61%. So that's kind of a gestalt on how the different treatment success rates are.
What was the blank?
Blank, they didn't have results on intermediate or high risk. Yeah. So this is that ProstATTack trial. We inject the virus, you take this pill, the cancer cells die, increase the immune response, and your body's white blood cells attack the prostate cancer anywhere in your body. Not only in your prostate, but if you have a few cells in your lymph nodes or something, it attacks it there too. This is the biggest study ever published on prostate cancer, 14,000 articles reviewed by Dr. Grimini, 2009, updated in 2012. Now, each article is a different symbol. That's not 14,000 symbols, obviously, because most of the articles had less than 5 years of follow-up or less than 100 patients. And if you don't have at least 100 patients, at least 5 years of follow-up, it's not such a great study. So this is all the articles that had at least 5 years of follow-up and at least 100 patients that were published in peer-reviewed medical journals. So these are, real studies. And what you see is that for low-risk disease, the beam, radiation beam is green, surgery is the right triangles, and the seeds are the blue dots, okay? There's a lot of overlap here. So for low-risk disease, you can do beam, seeds, or surgery. Relapse-free survivals are pretty similar. Maybe seeds a little bit better, but people do pretty well with any of the treatments. It's interesting when you get to intermediate risk disease. Because once you get to intermediate risk disease, that's worse cancer, there's a higher chance of cancers outside the prostate. So the surgical, pardon? The worse the cancer is, the higher the chances it's outside your prostate. Okay? So intermediate is worse than low risk. So they have higher chances outside the prostate. Low risk, you got 10 to 15% chances outside your prostate. Intermediate, like I said, 20 to 40%. High risk could be really high. And what you see here is the blue stars, beam and seeds are doing really well. Long follow-up, 15 years of follow-up with high cure rates. Surgery, the right triangle is not doing as well. And the beam without the seeds, the green boxes, not doing so well either. The problem, what's going on here is the beam therapy is limited in the dose, so it doesn't always kill everything in the prostate. The surgery is failing by missing the stuff outside the prostate. Do the beam and the seeds, the beam takes care of the outside, the seeds take care of the inside, you got it all covered. Yes?
Once you've gone through one of these, can you go back, for instance, Irish treatment, do you want?
Yes, if you have, I'm gonna get to that. That's the main part of the talk. High-risk disease. Pretty obvious. The beam and seed is doing much better than anything else. But if you look really carefully, there's beam, seeds, and hormones. So beam, seeds, and hormones might be better than beam and seeds for high-risk disease. So that's where you break high risk into good high risk versus bad high risk. And someone that's bad high risk, you have the hormones. If they don't, you don't need the hormones. Yes?
I'm trying to determine whether low or medium risk. A biopsy Gleason 8.
You're high risk.
Well, the pathology of Gleason 3 plus 4.
3 plus 4 is a 7.
Yeah, so it could be considerably higher. So a 7 is that?
No, if you're, I thought you said you were at least an 8.
Biopsy, looking at the pathology.
Oh, after surgery.
After surgery.
Then you go by the 3 plus 4 is 7.
Okay.
And we'll get to that too.
Can you
low
repeat?
risk.
You'll need to repeat
questions
questions.
a little bit or
Yeah,
ask
so
them?
the
It's hard
question
to-
was, somebody had surgery And the biopsy was a Gleason 8, which is high risk, right? But at surgery, takes the prostate out, and they see it's a 3 plus 4, which is a 7. So his official risk group now is a 7, which is intermediate risk group. Okay? So the biopsies aren't usually what happens when you have a biopsy. It goes from a 7 up to an 8 or a 9. But once in a while, it'll go from an 8 down to a 7. But most of the time it goes, biopsy looks better than the real thing in the prostate. 35% upgrade, typically. But there's occasional situations where if you have just a little small speck of an 8 on a biopsy, when they really see the whole prostate, they may downgrade it to a 7, which is better. All right, so there was a randomized trial, look at beam plus seeds versus high-dose beam, and what they find is that the relapse-free survival outcome was much better with beam and seeds than it was with beam alone. So I think we beat this pretty well. Now this was a huge study. I don't know, do you have the JAMA trial back there? That's an important article to have, actually. March 2018.
Oh, the PSA?
The Gleason 8, 9, and 10 cancers.
I don't think I do.
Okay, we gotta get you that one.
Yeah.
This is a groundbreaking article. It was just published March of 2018. And it looked at high-risk Gleason 9 and 10 cancers. These are the bad prostate cancers. And they took 12 major universities, UCLA, Joint Centers, and Cleveland Clinic, and they all combined all their data and looked only at the Gleason 9 and 10 cancers, which are the worst cancers. And they looked at the patients that were treated at those 12 centers with beam and seeds versus surgery versus beam without the seeds. And what they found is distant metastatic disease-free survival. What this means is a chance the cancer does not go to your bones. All right? It's an important endpoint. Beam and seeds, dramatically better than surgery or beam without the seeds. The chance that cancer doesn't go to your bones, dramatically better if you do beam and seeds compared to surgery or beam without the seeds. Yes?
See, you talked about, I think there's 3 different types of.
Doesn't matter what type. Yeah. Most people get iodine seeds. We've published papers on all 3 of them. Now, this is a little fuzzy, but this is cancer-specific survival. So this is the likelihood you don't die of prostate cancer. Again, beam and seeds, much better than surgery or being without the seeds. So it really makes a difference on whether you're alive or dead.
This study, I had my prostate cancer, so 15, maybe 4 cases. I was up on this day.
Did you talk to the radiation oncologist there?
Afterwards, because I had radiation.
Afterwards. The problem is a lot of guys who have surgery and never see a radiation oncologist till it's too late.
I saw one previously with that MSK, and he said because of my age, that I should do removal, because there's no studies with radiation long term.
That's not true. If you look back at what we just showed you, these are 15-year data. There's a lot more seeds data with 15-year follow-up than surgery. There's more data with long follow-up with seeds than there is with surgery. Okay? That's the fact. And there's no data showing that young age means you need surgery. There's no data proving that at all.
The doctors know that, or is it just because there's a prostate cancer?
Sorry,
Some
we
of
can't
us
hear
don't.
the questions. We cannot hear questions.
Okay, well, there's an issue on having to have surgery because you're younger, and there's no data, and there's no data, long-term follow-up data on anything except surgery. That's not true. Surgery has shorter follow-up than beam and seeds. Okay? More studies with follow-up on beam and seeds go out long-term than surgical papers. Period. It's a fact. You gotta get the data from your doctor. Just don't go by, well, I say this is better, therefore it's better. Got it? Where's the article proving it? This is cancer. You know, you can't just trust that they may not know. All right. And even overall survival is a little bit better. All right, so let's talk about recurrences. Take a little more. Recurrences after surgery. Let's say you had a radical prostate. We're talking about recurrences now. But that's basic outcomes we talked about in terms of how to prevent recurrences. Choose a treatment that's got a lower risk of recurrence. So let's say you had surgery. Half the guys in the country get surgery, half get radiation, right? If you get surgery, again, there's a good chance the cancer might be outside the prostate. So there's three things you need to see on the pathology report. You want to see if there was cancer outside the prostate. That's called extracapsular extension. You want to see if the seminal vesicles are invaded. And you want to see if the margins are positive. If any one of those three things is on the path report, that means your chance of having the cancer recur is much higher. 3 randomized trials where we flipped a coin, and half the guys that had one of those three things or more got radiation preventatively, and the other half waited until the PSA went up and then got radiation. All show if you get the radiation preventatively, you have low recurrence rates. And the one study that was powered to look at survival showed that if you got the radiation preventatively, you were twice as likely to be alive 15 years later than if you waited until the PSA went up and then got radiation. All right, so
Radiation C, is it the same thing?
they're both types of radiation. In this situation, the radiation is radiation B. You don't usually put radioactive seeds in a place where the prostate is removed because there's nothing to put the seeds into. And so if the prostate is removed and you're dealing with microscopic disease that's regrowing, you want to treat a broader area to kill all that microscopic disease. So that's radiation beam to do that.
I have a question about the Decipher test.
We're going to get to that.
Okay.
So the first step is you want to know your pathology. And if you have one of these three things, even if your urologist tells you don't go get radiation, you still should see a radiation oncologist. Both the American Urologic Association and the American Society of Radiation Therapy Oncology did a joint statement that if you have one of those three things, you better get consultation regarding radiation.
Once again, what are the three things?
Right there. Extracapsular extension, seminal vesicle invasion, or positive margins. Most of the urologists in this community are really good about sending patients. Unfortunately, there's 2 that are really bad about sending patients. So you've got to know for yourself.
Is the threshold for PSA increase solid radiation?
Is there a threshold for a PSA increase? Not really. The higher the PSA is at the time of salvage, the worse your prognosis. Ideally, you want to get the salvage radiation before the PSA gets to 0.5. We're going to get to that though. Decipher score. Okay, Decipher is a great genetic test. After someone has radical prostatectomy, and you're wondering, should this guy get post-op radiation preventatively? You can send a prostate specimen to San Diego, and then about 5 weeks later, we get the answer back on whether genetically the guys at high risk of having the cancer regrow were at low risk of it regrowing. So, this is it. If you have low risk for Decipher, so you have, let's say you have positive margin, like one of those three things. Remember I told you those three things? I'm not saying everybody with those three things have to get radiation. So if you have positive margins, and your genetic test comes back low risk, then whether you get the radiation preventatively or wait till the PSA rises, there's no difference in outcome. So on those guys, you can wait. You don't have to give radiation. You can just follow them. And if PSA goes up, then give them radiation. They do just as well. But if the Decipher score is high risk, if you give preventative radiation, the chance that cancer goes to the bones in 10 years is less than 5%. But if you wait till the PSA goes up and then give radiation, 35% chance cancer is going to your bones. So it's a very great, excellent test. So that's an important thing. You have surgery, you have positive margins, seminal vesicle invasion, or extracapsular extension, do the Decipher score, and help decide whether you get salvage or adjuvant therapy.
The question I have about the Decipher test is that it does more than just put you in low and high risk. It tells you that what your genetic profile is. So for my case, it said my response rate to radiation would be at the 14th percentile. My response rate to ADT was going to be 99th percentile. So I was wondering, what is the I'm getting radiation now.
Right.
Despite the fact that it had a 14 sunshine, but what I understood it to mean was that they took the genetic profile of people who took radiation, and only the ones that did well were in this category, the ones that didn't respond were in this category, and my genetic makeup is similar to the ones that don't respond to radiation. How can that be? What is it about on the genetic
Yeah,
level?
the subtyping on the Decipher score is not proven, okay? So you can't go by that little subtype stuff, saying whether, well, this gene pattern tells you you're gonna have a better chance of responding to chemo than the average person, or worse chance. You can't use that to make decisions. It's experimental. It's good for universities to use that to make an experimental protocol. But basically, if you have like a lower chance you may respond to radiation, I think radiation plus hormones versus radiation alone. Because the only thing that will cure you from a recurrence after surgery is radiation. Hormone therapy alone will not cure you. Anybody, period. All right?
Why would they have to back to the radiation?
Most of the guys around here do. You know, like the 15 surgeon, 18 surgeons in this area, all except 2 recommend radiation afterwards.
Sounds like you have nothing to lose at that point, right?
Well, yeah, the toxicity is pretty low. Yes,
Prostatect wouldn't be useful for recurrence?
prostatec's not used for recurrence because you have to have a prostate to inject the prostatect into. Yeah. All right. What's the role of radiation when you have, let's say you have radical prostatectomy and you have positive lymph nodes come back? What should you do? It used to be people would just put people on hormones and say you're not curable. But there's been 3 studies now, big, huge studies, that looked at the guys that got hormones alone in that situation versus hormones plus radiation. One of them is a national cancer database where all these centers send their information into this database and you can just slice and dice it and see what you see. And the bottom line is, the overall survival at 5 years was 71% if you only had hormones, but 85% if you got hormones and radiation. So adding the radiation made a difference. Another study is a SEER database. The same thing with them. Overall survival was better with radiation, and cause-specific survival was better when you added radiation compared to only hormones.
That's a 5-year survival?
Yeah, that was, most of this is 5-year data. Let's see, 6.5 year follow-up on this one. And then there's the Stampede trial, which is a huge trial with there's a huge number of patients. They slice and dice this up all the time. And that also showed adding the radiation improved the survival. The added radiation, the 2-year relapse-free survival was 85% when they added the radiation versus 55% if they didn't add the radiation. So there's a lot of studies you can use to help decide whether to get treatment. So the bottom line is, unless there's something, you know, you're really not in great shape, which is unlikely if you have surgery, because you're supposed to be in pretty good shape to have surgery. If you have positive nodes, especially if it's 1 to 3 lymph nodes positive, then doing radiation and hormones would be the best treatment. All right, so what if you do surgery and then your urologist doesn't recommend you get radiation? Or let's say you didn't have anything worrisome on the surgery, and so he wouldn't recommend radiation, but the PSA goes up later. That's pretty common. So the treatment of choice is radiation. That's the only thing that will cure you. But the question is then, should you add hormones or not to that? Because typically we'd only used to treat the area where the prostate used to be. Again, the Decipher test is helpful here. If your Decipher test is low risk, then treating the prostate bed only is a very good success rate, a low chance of recurrence. But if your Decipher score goes back high risk, treating the prostate bed only, you got a high chance of going through bubbles.
Excuse me, it's a scale of 1 to 10, what's the high and low rate on the Decipher?
No, the Decipher scale is from like 0.1 to 0.99,
Okay.
and the high risk is anything over 0.6. So 0.45 to 0.6 is intermediate. Now, there was another study done, this is not Decipher, but they looked at, whether adding hormones was benefiting people or not. And they looked at where the PSA was at the time you started the radiation. And if the PSA was less than 0.7 when you started the radiation, hormones hurt your survival. You had a 4% worse survival by adding the hormones. So radiation alone is the way to go there. If your PSA was over 1.5, then hormones improve your survival 25%. So it's a tight range there. So you gotta get those PSAs checked as soon as it goes up. I mean, as soon as it goes up, you gotta hop over and start seeing someone regarding radiation, because it makes a difference in how you're treated.
What intervals do you recommend outside of checking PSA?
Well, most people do like every 3 months the first year, then every 6 months after that. And then after 5 years, once a year.
What's the understanding about why the lower PSA, when you start your ADT with radiation, would result in a worse outcome? How do they understand?
Well, ADT has side effects. It can cause heart attacks, strokes, and other things. It changes a guy borderline diabetic into frank diabetes. It's got some serious side effects. You don't want to do it unless you need to.
You know, let's say 6-month period, a short-term ADT.
3-month shot. You increase the risk of heart attack.
ADT, the hormones?
Yeah.
I have radiation therapy for 3 years. PSA and also. Initially 0.5, 0.7, back down. Now it just up to 1.76.
So after radiation, the question is, PSA bounces around a little bit. It can go like 0.5, 0.7, back to 0.5, 1.5. She'd be concerned. Well, yeah, anytime it goes up, she'd be a little concerned. But a lot of things make the PSA go up after radiation because your prostate's still there. You have sex within a few days of your PSA blood test, that'll make it go up. Good buddy of mine, I could never check his PSA. It just never worked. A really long bike ride can affect it. Infections can affect it. Now, you don't want to go by just one PSA anyway. You want to see a trend of PSA rises on a guy who's not having sex for a few days or riding a long bike ride a few days before the PSA. And then if the PSA goes up then I give the guy a month of antibiotics and anti-inflammatories. And then recheck the PSA because it could be an infection. A lot of times it'll come down, but if it keeps going up, we move on to an MRI scan, T3 MRI and an oxygen scan. And frequently, what that will show is one part of the prostate where there's still residual disease. Because remember, external beam radiation is limited on how much dose it gives. So it sterilizes disease everywhere in the prostate except for one area. If that happens, then focal therapy to that area is a reasonable option. We have a protocol for that, for focal brachytherapy. We're doing that frequently, and I'm going to get to that. All right, so bottom line, if you have recurrence after radical prostatectomy, and the PSA is super low, and or the Decipher score is really low, then radiation of the prostate bed only works well. But if the Decipher score is high risk, or the PSA is over 1.5, then you gotta look at hormones for 6 months, despite the risk, because you get better survival, plus the radiation. And in that situation, you want to treat the lymph nodes too. Yes?
Where does chemo enter into this?
Doesn't.
Doesn't at all?
Not yet. There was a study for really super high risk guys where they gave adjuvant oxytocin chemotherapy for 6 cycles after radiation and hormones. And their 4-year relapse-free survival rate was a little better, but it wasn't overall survival, it wasn't cause-specific survival, the follow-up's really short, so it's experimental. So if I have a young, healthy guy that's got like Gleason score of 9 and 10 cores are positive and his PSA is 37, I'm going to do hormones, beam, and seeds, and have them meet medical oncologists to talk about the pros and cons of doing the chemo. And there's no protocol right now for that. If there's protocol, I'd be good to put on the protocol, but then he can decide for himself whether to take it or not. We don't have proof at this point. Yeah. All right, so salvage.
How often should you have your prostate checked?
Everything being normal, typically you should check once a year and a PSA once a year. Yeah. Okay, let's say you have recurrence after radiation now. We already talked about after surgery. What if the cancer PSA is going up after radiation, beam therapy, after radiation beam therapy? your options are surgery, cryotherapy, seeds, which is brachytherapy, hormones, or observation. I mean, if you got a guy who's like 85 years old, the PSA is just creeping up, and he's got some heart disease, which is observation, is a better way of going. If you got a guy whose PSA goes up to like 180, and he had really high Gleason 9 cancer to begin with, he's probably got micrometastatic disease, and probably hormones is better off. All right, so these are the salvage surgical studies. Guys who had radiation beam, the cancer regrow in the prostate, they got salvage surgery. And you see the success rate is anywhere from like 45% up to about 58% at making the cancer not come back, 5-year success rate. But the incontinence rate is really high. The lowest is 26% risk of incontinence, meaning wearing pads and diapers, and some of them are a lot higher. Impotency is practically guaranteed, and other major complications, which they don't always define, but it could be a stroke, heart attack, it could be a rectal fistula, is significant as well. So you could do surgery if the cancer comes back after radiation. Not necessarily the best option. They're a very big risk. See, here's a major study by Scardino and Stevenson and Eastham. So we're talking Memorial Sloan Kettering and the Kimmel Institute, and Stevenson is at Cleveland Clinic. And you can see the chance you were no pads was only 40% of guys weren't in pads. So most guys had pads. Because they're leaking, yes.
Regardless of treatment, what's the general population of prostate cancer survivors like regarding impotence?
Pardon?
Regarding impotence. Is it 3/4 of men forgetting salvage therapy will probably not have any luck with that?
If you have recurrence after treatment or just a de novo, fresh, virgin prostate?
Yeah, regardless of, yeah, without surgery. Right.
Okay, well that varies wildly, depending on your age and your health and everything. If you've got a guy in his 50s, is in good health, radical prostatectomy has about a 50% risk of impotency. Radioactive seeds have a 10% risk of impotency. If we're talking to guys in the 50s. If you're in your late 60s, over 65, surgery has closer to 70 to 85% risk of impotency, and radioactive seeds or beam therapy is equal to that, is about 22% risk. So there's a big difference between which treatment you choose, okay? But if you're not, that's on guys that have good function to begin with, too, all right? So it's not true that regardless of what treatment you're going to be impotent. That's totally not true. Depends on your age and your health and which treatment you choose. What about salvage HIFU? You know, using HIFU to burn the lesions, there's almost no data. So the follow-up was very short. Number of patients were small. Incontinence rates aren't always listed. Fistulas, maybe, maybe not. They're not. The data is like not good. There's not enough data to make any decision on it. Cryotherapy, there's a lot of studies, and they have outcomes that are right up there with surgery. See, but the risk of incontinence is a lot lower than surgery. Impotency is still high. The risk of fistula, you know, maybe a couple guys out of 100 may get a fistula. It's a hole between the rectum and prostate, which is really bad, okay? But it's pretty low. Certainly not the 35%, 20%, 16% high major complications rates you saw with surgery. So this is looking like a pretty good option for guys to get recurrent disease in the prostate. What about seeds? Lots of studies on seeds. Success rates are even higher. Incontinence rates are low, like similar to cryo. Fistula is pretty low. There's one here. There's a couple here. And stricture, which is scar tissue of the urethra, in about 10 or 15% of patients, which you can dilate and stretch out and fix. So there was a big study done in the United States, 100 patients, multiple centers. No rectal fistulas. The whole prostate was treated with seeds. 10 to 15% of patients developed scar tissue in the urethra that had to be stretched out or dilated by the urologist, but that's something you can do and fix. Some patients got a lower dose of seeds than other patients. The patients that had lower doses of seeds had less side effects, but the cure rate wasn't less. All right, so what does that mean? What about focal brachytherapy? Because you gotta realize that after radiation beam, the beam has already sterilized microscopic disease throughout the prostate, but the dominant lesion in the prostate, maybe the dose wasn't high enough for that, so the recurrence may be only that dominant lesion, because everything else has been sterilized by the beam. So treatment to only that dominant lesion might be a reasonable option for you. And so this study showed that 60% of guys 3 years after treatment did not recur, and the toxicity was almost nothing. So very well tolerated treatment. So here's a summary of options after radiation beam recurrence. I mean, biopsy proven recurrence in the prostate. Surgery success rates, about 50%, cryo, about 45, 50%, seeds, 65. I threw out the best study and the worst study and got the middle of the range here, okay? Seeds, 65 to 70, except for these two, there wasn't that many studies. So it's just one study here and only a couple studies here, took the average. Incontinence, 50% or so, low, low, 0, and pretty high for HIFU actually. Rectal fistula or major complications, pretty high, low, 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 and not really clear on this.
So
Radical prostatectomy, take the prostate out.
seeds would be the best option.
Seeds or cryos, my feeling, looking at all the data, is that either cryotherapy or seeds makes the most sense in a recurrent setting. Now,
After radiation.
after radiation beam therapy,
Right.
if a guy's got disease in seminal vesicles, he can't get cryo. And so we have a protocol right now for focal salvage brachytherapy for recurrences. But we're doing this all the time. The guy gets PSA rising, it goes up and up and up. Do the T3 MRI, do the oxygen scan. The disease is only in one part of the prostate. We biopsy the whole prostate, do a mapping biopsy. If it's only positive in that one area, that part of the prostate gets seeds, nothing else does. Guys are tolerating that well. Probably do at least one a month. Yes.
Most of your patients are asymptomatic at that point?
When they get the treatment, they're usually pretty asymptomatic. Now, after we treat them, they're peeing more often for several
Right.
months. Yeah. But that's a temporary thing that lasts about 4 to 6 months. Yes.
PSA the only test for recurrence?
This is the best test. Now, if the PSA is going up, that doesn't prove there's cancer. To prove there's cancer, you want to do an MRI scan, oxygen scan, and you've got to do a biopsy to prove there's disease there.
And you should have at least maybe 2 high readings.
2 or 3 readings going up and not have had sex or a long bike ride ahead of time, and probably do some antibiotics.
If you had a radical, would there be any test for recurrence?
Yeah,
How
PSA.
would you know?
If you have a radical, the recurrence test is again PSA.
Okay. And
Any
the
recurrence in
threshold
prostate-
is,
Threshold is detectable. You should have no detectable PSA after radical.
what, is that 0.05 is not detectable or is?
It depends on your lab. So what's the threshold after surgery? Most labs use super sensitives, it's less than 0.04, less than 0.02. You know, it should be undetectable. Now, if it's only 0.02, you want to follow that, because once in a while they leave a little benign prostate tissue behind, and if it stays flat at that, then that's okay. But if it goes to 0.03, 0.08,
progression you're looking
it's
for.
progression also. All right, so that's the protocol I just told you about. And this is an example of a patient we treated. His disease was here, so we treated his right side of the prostate, and there was some atypical cells in the left apex, so we gave some seeds there at the left apex. Okay, if someone fails after HIFU or cryotherapy, the standard treatment is usually external beam radiation. Sometimes we do seeds too, but sometimes the prostate is so deformed after the cryo or the HIFU, it's kind of tricky to do the seeds. Newer is not always better. As you saw earlier, proton beam therapy at a higher risk of rectal side effects did not have a better cure rate. Robotic surgery is pretty much equal to open surgery in terms of important things like disease-free survival, incontinence, and impotency. But you're out of the hospital quicker, and if that's what your doctor knows how to do, you do what your doctor knows how to do. HIFU had a lower cure rate than radiation or surgery and a higher risk of incontinence. The FDA data, when they reviewed it, found it neither safe nor effective, so it's not approved for prostate cancer treatment. That's why insurance doesn't pay for it. neither safe nor effective.
What about, IMRT, brachy, and hormones?
Guy has very high risk disease, trimodality therapy, IMRT, brachy, and hormones. That's what that JAMA article I showed you was, yes.
How long are you supposed to stay on the hormones?
Well, it depends what you're doing.
Metastasized.
If you're doing external beam, brachy, and seeds, it's typically a year. If you're not doing the seeds, then it's 18 months. How long do you keep the hormones going?
What if you're on it more than a year and you've done all those things?
Well, if you're on the hormones for more than a year and your PSA is undetectable, there's no data saying you should stay on it.
Still on it.
The NCCN criteria used to say 2 to 3 years of hormones with being for high-risk disease. But randomized trials are now showing that 18 months, 3 years, but a lot less side effects. Not all the doctors know that study, because this is the radiation literature, it's not in the urology literature. So if you get radiation, the urologist is giving you hormones, he may not know that, hey, a study showed 18 months was as good as 3 years.
Which leads me, again, I raise this with a lot of doctors. How much do doctors know about these bigger statistics as far as recommending continued hormone treatment when in fact what you just said seems to apply?
A lot of them don't.
And what's to be done about that?
Well, it's challenging because everybody's really busy. You know, there's more patients. There's like almost the number of patients is doubling compared to the number of doctors. You don't have time to go all the meetings, and you're so busy seeing 30, 40, 50 patients in a day. It's hard to keep up. So you want to go to someone who's going to the conferences and hopefully subspecializes in that one disease and hopefully is really reading the literature. But you just don't know.
Isn't that the role of the medical oncologist who specializes in prostate cancer?
There really is none. I mean, there's one in town that just moved to town, but the medical oncologists don't deal with prostate cancer, except for metastatic disease. And, you know, widespread metastatic disease they do it, but with this kind of data on the low, intermediate, high-risk disease, they don't know this stuff. It's not in the literature at all. They're not expected to know this stuff. They got to deal with breast cancer, lymphomas, and leukemias, and all this other stuff.
Do you have the risk factors for side effects, salvage radiation after aortic prostatectomy?
Yeah, the side effects of radiation after radical prostatectomy. If you just need the prostate bed only treated, more frequent bowel movements, some tiredness, and maybe more frequent urination. That happens during the treatment and disappears a few weeks after you finish treatment. Impotency, if you're having good erections ahead of time, you got about 25% risk you lose your erections.
They're already done.
And most of them are, so it's not usually an issue. And incontinence is about a 2% risk it might cause incontinence. You guys weren't incontinent after surgery, but that data is kind of tricky because they don't always really review how good the continence was before the radiation. And as you get older, you have a higher, after you've had surgery, the longer you go after surgery, the weaker your pelvic floor muscles are and the higher the risk of incontinence. So if you look at the 10, 15-year studies with surgery, there's not many of them. But the guy that developed the laparoscopic surgery, I invited him to give a talk with me at Seattle, and he does have 15-year data, and he showed the risk for incontinence went way up with long follow-up after surgery.
I got 100% confidence 2 weeks after surgery, so presumably on the low risk then for side effects.
You'd be expected to be low risk for problems, yes. Yeah, except for some temporary. Now, if your Decipher score is high, or your PSA is over, 1, then you need hormones and lymph nodes treated. If you treat the lymph nodes, you're gonna get some diarrhea probably temporarily. And if the hormones will cause a lot of side effects temporarily. Yeah. Yes.
Question in my mind, what do the hormones come into play? In my case, if in fact I have radiation, things keep going.
So the hormones come into play if you have, say the PSA when the hormones come into play after radiation beam failure. So if you have PSA going up and up and up and no sign of disease in the prostate, so you got microscopic disease somewhere else in your body, then hormones come into play, because you got to treat the whole body. But if you have only disease in the prostate, salvage local therapy is usually a good option, and you don't necessarily need hormones with that. Or maybe just do 3 to 6 months of hormones and then back off.
That's best determined by.
The Oxygen scan and the T3 multiparametric MRI, and if one of those is even if it's not positive, mapping biopsies, we do transperineally, just like a seed case, do 30 biopsies of the prostate. Cover top, bottom, left, right, in and out, the whole thing.
What is the maximum?
While you're asleep.
Yeah.
Blood in the sperm, after treatment, after radiation, doesn't mean anything. It's just the blood vessels weaker and it can break and you get a little blood. Once in a while, someone will have blood in their sperm, they'll have some cancer in their prostate. Whether it really is associated with prostate cancer or just a coincidence is hard to say. So if you have blood in your sperm and you haven't had a PSA check for a while, I get a PSA check. If it's, remember, 25% of prostate cancers are in guys with PSAs under 4. So don't look at 4, look at your trend. If you're running PSAs around 0.8 and then it goes up to 2.5 and then 3.5, that's bad. You gotta get that looked at. Under 4 doesn't mean it's good. So you gotta know your trend of your PSAs, you gotta track it out. You gotta trend your PSAs, yeah. Trend, write it down on a graph or something. Engineers are great, they graph out their PSAs. They take a long time to talk to in the consultations, but do their research.
That's a question.
Yeah.
What is the?
No, you can't start really early. You gotta bring them back
The
and more
question
testing.
Question.
Yes.
What's the maximum dose of radiation one could take when we consider EBRT, and if the patient has already 80 grays, can they still take the seeds?
Oh yeah, we do salvage seeds on somebody if they recur after the 81 gray. We do that all the time. If they recur.
If they recur.
Yeah, now if you just had the 80 gray and you don't have recurrence, we don't go throwing seeds into you because you might just be cured with the 80 gray.
So if you want to exceed the 80 gray, are there more side effects or complications, like secondary cancer and so forth, from if we implant seed?
If we go to more than 80 gray
Right.
with the beam,
Uh-huh.
if you go to the higher the dose of the beam, the better chance you get rid of the cancer, period. Studies of Memorial Sloan Kettering show if you go to 86 gray, the intermediate risk patients have an 87% relapse-free survival compared to only 78% success rate if they go to the standard 81 gray. So a higher dose is better, but those guys had worse side effects too. Now we are going to higher doses more now for a couple reasons. One is the MRI scans frequently are showing just one dominant lesion in the prostate. So I give 81 gray, and the guy that say can't get seeds or doesn't want seeds, I give 81 gray to the whole prostate, but that one part where there's a dominant lesion on MRI that's biopsy positive, I'll give that 90 gray. And that's well away from the rectum, and I can do spacer injection too, a gel that you can inject between the prostate and rectum, moving the prostate away from the rectum so the rectum is even a lower dose. So there are ways of managing this, but if you got bilateral disease, you know, base, apex, left and right side, you can't really safely dose escalate to much above 81 gray without running into some rectal or bad urinary problems. Permanent.
So the seeds gives how much, it adds how many more grays?
Well, when we do seeds, we plan ahead of time, beam plus seeds. So they'll get 50 gray with beam and 108 gray with the seeds for a total of 158 gray. But that's to the outside of the prostate. The inside of the prostate where the cancer is actually getting, you know, 200, 250 gray. Dramatically higher doses. Now we have, you know, like 150 gray at the urethra, 250 gray in the peripheral zone. It's complicated dosimetry, but you'd have to see a map of that.
And so the chance of secondary cancer?
The secondary cancers, there's a lot of database on secondary cancers, and if you get radiation beam therapy, then there's like a 1 out of 200 chance you might get a cancer of the rectum or the bladder 10, 15 years down the road, most of which are low grade and easily cured. If you get brachytherapy, the data didn't show any increased risk at all. The longest study was published by me about 10 years ago, 15-year follow-up, about 300 patients. Yeah. Any other questions?
Yeah, I'm due to get some D-Garlex injections
Yeah.
next month. And I was wondering about the immediacy of the side effects.
Even with the Degarelix Firmagon injection, the testosterone comes down fast, but most guys, it takes them 2 or 3 weeks before they start getting hot flashes and stuff, but they need the hormone.
And that's gonna be frequent, and that's gonna be, last forever.
Depends on how long you're in the hormones for. If you're on the hormones forever, yeah, the side effects will last.
Yeah, I don't know, it's early on.
Well, not typically, usually it's a short course.
Oh, it is.
Done, you know, you start it before and during the radiation, and then you stop it,
I never had radiation.
you're just getting hormones alone?
After radical.
Oh, so the PSA is going up after radical?
Yep.
And you never talked to somebody about radiation for that?
No, I did 2 people, and they suggested it would not be beneficial.
Because PSA was too high?
Correct.
Okay. Yeah, well then you go on the hormone therapy, and there's cause for, you could go on it permanently, or you could go intermittently, where you take it for like a year, and you stop and watch the PSA, when it goes back up, you go on it again. There's pros and cons to those, and your urologist can talk about the pros and cons of that.
Will it change that dramatically my lifestyle, presuming that I was healthy and continued to be very active and so on?
Well, the main downside with the hormones, if you go on hormone therapy, I strongly recommend somebody walk 45 minutes a day, at least, and they lift weights every 3 days. And you take calcium supplements.
Okay.
And you eat heart healthy. You watch your blood sugar and your cholesterol, or your triglycerides, because that can be thrown out of whack by the hormones. You do all that stuff, you can do very well on the hormones. I mean, you won't have erections and stuff, but everything else could go pretty well.
Okay,
Yeah.
thank you.
Also, if you could do a penile rehab while you're on the hormones, you could do
It doesn't usually work when you're on the hormones.
I'm on the hormones, and so I'm doing twice a week injections.
Well, injections can help, yeah. But the pills alone won't.
Tissue.
Injections and the vacuum erection device and that sort of stuff, yeah.
Sure, the radical prostatectomy, the robotic, they took out lymph nodes.
Right.
And I have 2 questions there. If someone's just having radiation, do they take lymph nodes or not? And secondly, I ended up with lymphedema. Is that typical or not?
Yeah, so the thing was, with surgery, they take out lymph nodes. They don't usually take many lymph nodes out.
2.
Yeah, that's like nothing.
Yeah.
Okay, so in the United States, unfortunately, radical prostatectomy, most surgeons only take out less than 5 or 6 lymph nodes. And so then when you look at the part tables for your risk of lymph node invasion, and underestimate your risk of having cancer in the lymph nodes. Surgical studies in Europe, they take out 20 to 40 lymph nodes. If you have gynecologic cancer or rectal cancer, it's 20 to 40 lymph nodes. The only people that take out the small lymph nodes like this are urologists in the United States. So you're not getting your lymph nodes treated. If they're negative, it doesn't mean anything because they haven't looked at enough lymph nodes. If they're positive, it means something. But if they're negative, it doesn't mean you're clean. So we go by the risk of the lymph node invasion based on the part tables and something called the Roche formula. And if your risk for lymph node invasion is more than about 15%, then we treat the lymph nodes with radiation. Radiation is the only thing that really can treat all the lymph nodes.
So,
And the risk of lymph node invasion and lymphedema after treating the lymph nodes with radiation is very low. Unless someone's had surgery and already has lymphedema, then the risk goes up.
now, but if someone just has radiation, do you take lymph nodes then or not?
Well, we do an MRI scan, and if we see disease that looks suspicious on the MRI scan, then that lymph node packet will get a higher dose of radiation, and it'll get hormones too. All right?
Wow.
Any other questions? All right. One more, yes.
When you say MRI scan, is this a fusion-based MRI or just a plain?
Well, most of the time, I'm just talking about the regular T3 multiparametric dynamic contrast enhanced MRI. Just that one. No, MRI fusion is used to fuse an MRI with the ultrasound to do the biopsy. 2 ways of doing that. One way that most people do is the biopsies go through the rectum. The other way that we do, especially when there's recurrent disease, working with, say, Dr. Billick and Perry here in town, or all the urologists in Bradenton, we do a transperineal biopsy, because that, you don't go through the rectum, the risk of infection is much lower, and we get the anterior part of the prostate better and really map it out at the same time, and that's like doing a seed implant, only instead of putting seeds in, we're taking little pieces of prostate out. Not that many, there's only about maybe 15 people in the country doing that right now. Yes.
After an RP with the increasing PSA, how do you determine if it has metastasized to the bone or whatever? How do you?
Well, you do a bone scan, and you can do an oxygen scan too, if you have a rising PSA after any treatment in your Medicare age, yeah.
What was that?
The oxygen scan, it's a special, like it's like a PET CT scan that specifically looks at prostate tissue. Much more sensitive than a regular bone scan or a CAT scan. But if your PSA is going up after surgery, and it's less than like 3 or 4, you need to see a radiation oncologist. Period. Yeah. All right.
I think
I think that's bad.
we better wrap up here. We've got a massive amount of information.